Hello, I'm Dr. Dupper, a family medicine physician and member of the medical education team here at CUSM. In this video, we want to review some of our best practices in assessing our students' performance. Thank you for your interest in this. Thank you for your time and effort in training our students. It's very much appreciated. Our goals for this video is to be able to strengthen your expertise, your understanding in our curriculum and where your assessments fit within that curriculum. Our hope is that this makes things more efficient for you, that you can complete these assessments faster and easier with less effort in your busy day. We'll also make sure that as a part of that, it's improving our students' experience. And overall, at the end of the day, our goal is always to improve the integrity of these student assessments. So we'll go through some of the educational context of your clinical performance evaluations and where they sit, as well as some meanings and intent behind these scores and assessments, as well as some examples of how to align our feedback, both narrative, written, and scored, to be able to provide that strong support for students' training and their improvement, with some examples. So as a reminder, for those of you that are training our students in the clerkship phase of education, the 12 months of core clerkship fits in the middle of this 4-year MD program. Students who enter the clerkship phase have completed 18 months of pre-clerkship training that allows them to enter actively with strong training in clinical background. They also can enter at the January or July semesters. Students have a choice to enter core clerkship training or professional development semester when they begin their clerkship phase. And our 4th year of training that also encompasses these assessments is our transition to residency phase, where we're supporting students in their sub-Is and electives. Also relevant to dive in a little bit deeper, that your core clerkship evaluations have both a formative and a summative component. Our dual pass curriculum means that students are rotating through 6 of our core clerkships twice. So that first evaluation in this example schedule for a student who's completed the first 4 weeks of general surgery, that assessment, that evaluation that you're completing for that student is at the midpoint. It's the formative evaluation of their surgery performance in this core clerkship so far. The exceptions here are emergency medicine and neurology, which are both single pass. Also, as a reminder, your assessments of students' performance are a significant and valuable part of their overall grade and how we assess their performance. 30% of their overall clerkship score is your assessment of their performance using our student performance evaluation. That's important because we value their clinical skills, their ability to take care of patients, and those activities that are crucial for us to rely on our future colleagues. A few notes on the design of this. It's based on AAMC language so that we have a shared understanding of expectations for our students' performance. We want to make sure that our MD students graduate with an expectation that's consistent with their peers around the country. We know that our students are exceptional, and so it's useful for us to have those national standards to really highlight their high quality performance and how valuable they are for residencies who are recruiting them. Given that, we use these EPAs, the Entrustable Professional Activities, within our community of practice and adjust the language as our faculty and community providers find relevant to our care of patients. So a few notes within that. I want to point out that when we are entering and discussing orders and prescriptions, when we're assessing that on item 4 for the EPA, we recognize that not all systems allow for students to be able to pen orders or to participate within that supervising capacity. Given that, faculty have used strategies such as having students write it on a piece of paper that can then be shredded appropriately, or to be able to have that discussion verbally and consider what would be the next step of orders to the detail that is important for our students to be able to identify. Said another way, we know that our students aren't licensed physicians. They can't actually sign orders, but they can discuss them and they can write them, and they really need to learn how to do that. And so our job as faculty is to support them in that process. I also want to point out the importance of recognizing and knowing the process of informed consent. So we, again, know that our students can't do that independently, but they need to be able to recognize when this is required, what are the components of it, how would you begin that conversation with the patient. And some strategies that faculty have used for that is to be able to have a conversation, to discuss and use script examples to be able to provide that training for students, to have the students play back to them as faculty. What would you say in this situation? How would you engage with the patient in this way? Also making sure that students have access to those encounters when you're the one completing it. So I like to have students with me when I'm completing informed consent, quizzing them perhaps before and after about those key pieces, how they would have answered something, or what if scenarios if a patient had asked a specific kind of question, and then assessing their understanding of that process. And a similar note with procedures. Procedures look differently for all of us. In family medicine, I want to make sure that my students are engaged when I'm doing a procedure, an injection, a LARC insertion implantation. In other departments, that can look very different. And a key note here is that procedures can also be procedural assessments of patients, a MOCA, for example, or other cognitive tests that are quite procedural, and the interpretation of those can be something that students really need to be able to engage with and make sure that they have that training. So if you have questions in your practice, what would a procedure look like? Please reach out to us. I'm happy to clarify and work through some examples. So we've covered what are these entrustable professional activities with some thoughts on how to apply it specifically to your clinical setting. I want to focus on the scale for a minute and make sure that you feel comfortable assigning a score in our 6-point differentiation of students' performance. You'll note this language is quite intentional and has a bit of design behind it within our curriculum. I want to highlight the item number 4. When you are noticing that a student can consistently perform activities with your supervision, but maybe not with prompting or with intervention, that means they have that skill. They've met that ability, and that would be aligned with a passing score. A student who is exceptional, above average in what you would expect a medical student to be able to perform, who is well above their peers, and perhaps even a rare example of a high-performing student, those would be our 6-level performances. So as you're reviewing each of those EPA items, students will have different skill sets. Many will be fantastic students in some areas and be appropriately passing and doing a good job in others. But overall, our average of 4 is what we denote as passing, of meeting those milestones and key entrustable professional activities. Moving through the assessment process, the really important piece of your comments, your narrative feedback, is something I want to spend a few minutes discussing. In the items that you'll see, they're at the bottom after you've clicked through those entrustable professional activity scales, and there's formative and summative narrative boxes for you to be able to provide some examples, some feedback for students. The formative evaluations are important to include for students. These are things that they can improve on for next time, whether it's in the first pass or second pass. In their summative, there still could be things that are worthwhile for them to improve on, some formative, crucial feedback for them. Summative comments are eligible for our dean's letter. It's important that students have specific observed performance metrics that you can provide. We want to make sure that they have a crucial piece of their training that's put in that narrative comment. Your appraisal of their performance in a narrative is extremely valuable for our students for several reasons. The first is what we've reviewed here, that it's part of their foundational training to make sure they're meeting these milestones, that they are progressing through the curriculum. The other is that the audience for this is their dean's letter. So program directors, residency faculty are reviewing these comments. And those of you who work in that space know how valuable that is and what's important to put in those. So as you're writing your feedback for students, please consider that the audience is both the student and their training and learning, as well as future faculty who are reviewing them and recruiting them for their residency. So I want to share some examples of things that we recommend and things that we don't recommend that we've seen over the years. When we're busy at the end of clinic and you've had a good student, it's very tempting to write good job. But I want to emphasize that that's not meaningful for our students, nor is it helpful for the program director audience. I also want to point out some pitfalls in commenting on a student's interest in that field or their students' performance or their engagement or meekness, as well as the curriculum itself. Any of these things aren't relevant to the student's performance and actually can be quite damaging. So instead, we would recommend specific observable skills that the student has performed that you've witnessed. So good job with organized and efficient presentations. Did they take initiative consistently to take care of patients? Was there a specific story behind this? Can you give an example of a patient that a student participated in the care of? That would be the highest value in a narrative feedback. A couple other key things to consider when you're drafting your narrative feedback for students. Sometimes it can be helpful to ask yourself some questions in that formative setting. What would be useful for the student to improve on next time? What are some things that I would recommend for them to read or to practice? Another thing that's crucial here is that you want to match the verbal feedback you've given to students throughout rounds on a day-to-day basis. If you were giving them some notes and some suggestions on their documentation or on their presentation style, those are helpful to include here so that it is a record for the students so that they can understand and incorporate that feedback in a more valuable way. In the summative section, what are some specific things? Are there vocabulary tools within the assessment itself that I've noticed a student is exceptional at? So you can go back and look at those EPAs and use that to help fuel a description of the student's performance that I hope is useful to you. I also want to say that it's worthwhile to consider your own style, your own way of assessing students, and there could be some shared language between students. However, the strongest, most valuable feedback is something that's specific to that student, that's relevant for them and their independent performance as it's viewed by program directors. I'm going to take a minute more to talk about aligning that verbal feedback and the written narrative feedback. I mentioned it in the last slide, but I want to give some examples of verbal feedback and how that could be related to a score or some narrative feedback that is included in the evaluation itself. So your presentation was missing some key components. You need to work on your differential and supporting that when you present it. These are narrative feedback examples that are on the weaker side. Could be in the 3s range, maybe a first pass student who hasn't quite gotten to these milestones yet. Moving forward, the examples of verbal feedback I would give to a student saying, good job, you presented that case well today, you've made significant improvements. Those could be students who are meeting milestones, who are consistently performing. That could be in the 4s range. Moving forward to a fantastic student who you're saying, you performed at the level of an intern today. I was really impressed with the work that you did. Your cases are efficient and really thorough. Well done. Those would be the scores for an exceptional student in that 5 or 6 range. And also examples of things that in writing would also be very valuable to our students. So in closure, some take-home points. Your evaluation and feedback for students is crucial. It is a key part of their MD curriculum and their clinical training as a future physician. What you're doing and the time you're spending in your thoughtful appraisal is very much appreciated. Your verbal feedback helps them to learn how to do these skills, and your assessment of those skills is crucial. Lastly, a reminder that what we write in the student's record, whether it's their transcripts or their dean's letter, it's crucial for them and the rest of their career. And so as we write these, considering not just the audience of the student, but our colleagues in residency training and their appraisal of the fit for this student is crucial. Thank you very much for your time and attention in both this video and in training our students. Thank you.